Alpana Sowani from Mumbai, and my topic today is antibacterial drugs and topical agents in the management of diabetic foot. Since we are running a little late, I'm going to move through these slides really quickly and then come to the main part, which is the antibiotic therapy. Diabetic foot is defined as the foot of diabetic patients with ulceration, infection, and or destruction of deep tissues. It is always associated with neurological abnormalities and various degrees of peripheral vascular disease in the lower limbs. Diabetes is the leading cause of non-traumatic extremity amputation, and this is because of the involvement of neuropathy, abnormal foot biomechanics, peripheral arterial disease, and poor wound healing all together in a single patient. In which diabetic patient should we suspect an infection? Actually, every patient. Any patient who shows any signs of inflammation, they could be subtle or they could be frank signs of inflammation. The subtle ones might be just an increase in secretions, or there could be undermining of the wound edges, or just plain foul odor. This is a typical example of the diabetic foot that we see. My topic today talks about the IDSA guidelines. What is IDSA? It's the Infectious Disease Society of America. They have very clearly put down guidelines about how a diabetic foot should be managed. First of all, we come to the clinical classification as per the IDSA. It is divided into 4 groups. That is uninfected, mildly infected, moderate infection, and severe infection. Now, our uninfected foot is, there are no symptoms and signs of infection, which we all know are rubor, erythema, heat. All these are the typical signs. So, when a wound comes in without any signs, it is an uninfected foot. When there is a local infection involving only the superficial layers, only the subcutaneous tissues, without involving any of the lower tissues, and the size is between 0.5 centimeters to 2 centimeters, this is a mild infection. When the size increases from more than 2 centimeters and it starts involving the deeper tissues, it could be the bone, it could be osteomyelitis, it could be fasciitis, it could be just an abscess formation, that is a moderate level of infection. And whenever a moderate infection gets accompanied by other signs of inflammation, that is, you get an inflammatory response, that the patient is throwing a fever, the counts are very much higher than 12,000 or lower than 4,000, the respiratory rate starts increasing. These are all signs showing that their patient is having a severe infection. Also, the IDSA classification helps talk about the incidence of hospitalization. Generally, in an uninfected wound, there is no need for hospitalization. For mild infection, 4% of patients are admitted, and moderate infections, up to 52% of patients require admission purely for parenteral antibiotics. And for severe infections, up to 90% of patients might require hospitalization. Now, how should we assess a diabetic patient presenting? We recommend looking for PAD, vascular insufficiency, any abnormal foot mechanics, as well as any biomechanical problems. Also rule out the presence of neuropathy. Now, how do we get a specimen should we do culture in all patients? Now, a patient who doesn't have an infected wound, no, we don't require a culture. For most patients with a mild infection as well, if he has not received antibiotics, a course of antibiotics before meeting you, you do not require a culture. We can give a broad spectrum antibiotic. But most patients with a moderate to severe infection will definitely require a culture. How do we obtain a culture? Please avoid doing a swab specimen because we might get an inaccurate reading on the culture report. What we suggest is either get a biopsy or curettage after the wound has been cleansed and debrided. Only then will we get a fairly accurate value about what is the culture sensitivity, what is the antibiotic sensitivity of the wound. Okay, then. What are the antibiotic regimens based on the severity? I think I will just go through these because I have good, we can come to this. The antibiotic selection overview. These are the IDSA guidelines about how should we start. Is there any clinical evidence of infection? If no, do not treat the patient in a clinically uninfected wound with antibiotics. Now, for a patient who has a clinically infected wound, the first question which we should ask is there a risk of MRSA, that is methicillin resistant Staph aureus infection? If yes, then we will give anti-MRSA treatment. If he has received antibiotics in the past month, then we will give we will talk about which antibiotics have to be given. I'm just trying to go stepwise. If the patient has not received antibiotics in the past 1 month, then we will give them antibiotics which are going to work only on gram-positive cocci. If he has already received one course of antibiotics, then we will have to give the patient an antibiotic coverage which includes both gram-positive and gram-negative infections. Is there any risk factor for Pseudomonas infections? Now, in diabetic patients, we do not see too many Pseudomonas infections. But if a patient is a high risk for Pseudomonas, that is coming from a warm climate, or the feet are warm very often, wet very often, such patients we do need to keep in mind Pseudomonas, and they will require treatment for Pseudomonas as well. Otherwise, they rarely need pseudomonal cover for a diabetic foot infection. How do we diagnose and treat osteomyelitis? Osteomyelitis is basically the bone involvement of a diabetic foot. When should we think about it? Any infection, abscess or ulcer over a bony prominence, we should try and think about osteomyelitis. How would we do this? It's a PTB test, a probe to bone test. Always try and do a probe to bone test for any diabetic foot infection with an open wound. MRIs help. We can sometimes do antigranulocyte scans, or the best way is to do a culture, to do a histology, to do a biopsy. They are the best ways to find out final diagnosis for a osteomyelitis. Now, what are the empirical antibiotic regimes? I told you we have these charts which are really useful. Now, depending on the severity of infection, the IDSA has laid down these guidelines. In a mild infection, it can be generally treated with oral agents. The most probable pathogens in this case are the MSSA, that is methicillin sensitive Staph aureus, and streptococci. The antibiotic agents of choice here are either dicycloxin, clindamycin, cefalixin, levofloxacin, and the amoxiclav combination. Now, clindamycin and amoxiclav, they have a good broad spectrum coverage. Clindamycin also works to some extent over the MRSA pathogens. Now, when you have an MRSA pathogen, the drug of choice would be doxycycline or trimethoprim sulfamethoxazole combination. In this case of a moderate infection, generally we would prefer to start with parenteral therapy and then continue with oral therapy. The aim of, we cannot give parenteral therapy throughout up till the wound heals, but we should give parenteral therapy up to such time that there is some resolution in the amount of infection, not up to the time of healing of the wound. Now, the pathogens involved in moderate infections are the streptococci, the Enterobacteriaceae, and the obligate anaerobes are present. Which are the drugs of choice which we should use for moderate infection? It's levofloxacin, cefazolin, ceftriaxone, they are ampicillin combination, moxifloxacin, ertapenem, tetracycline, and levo or ciprofloxacin along with clindamycin. Each of these drugs have some positives, some negatives. It could be cost, it could be the spectrum that is covered, it could be presence of other, if there is already a kidney function decrease. So we have restrictions even in the amount of dosage we can give in. So depending on what the patient's status is, we need to choose our antibiotic. Another good combination is imipenem celastin. It has very, very broad spectrum, but it does not work under the for the MRSA and pathogens. But it works very well when the ESBL pathogens are present. The other group of drugs which are good for the MRSA and moderate infections is the linezolid, the daptomycin, and the vancomycin. The few cases where Pseudomonas infections are present, the drug of choice will be piperacillin along with tazobactam. Now, the next thing is when the infection is very severe. The pathogens here are generally MRSA or their Enterobacteriaceae, Pseudomonas along with anaerobes. So here the treatment is generally more than one antibiotic. Vancomycin +1 of either ceftazidime or cefexime or the piperazobactam combination or a carbapenem. Now, we've spoken about which antibiotic can be used depending on the severity of infection. I'd just like you to have a look at these antibiograms which were covered at the St. Patrick's Hospital. For the gram-positive and gram-negative infections, they have given you which specific antibiotics they found to work best. Now, the most common gram-positive organisms which they found in all the cases that they studied and in the study which happened was the Enterococcus species and the staph species. Both of these are gram-positive. For the Enterococci species, ampicillin and vancomycin were the drugs which worked best. For the staph species, where IV antibiotics were required, it was seen that vancomycin and oxacillin were the two drugs that worked best. In the case of staphylococcal infections, where oral therapy was required, the drugs of choice were clindamycin, doxycycline, and trimethoprim sulfamethoxazole combination. In the antibiogram, where the gram-negative organisms were studied, the different organisms were the E. coli, the Klebsiella, and the Proteus. These are the most common ones. And the drugs of choice for these were the cefazolin, ampicillin, and the ceftriaxone. They worked for the E. coli and for the Klebsiella series. It also worked for the Proteus species. The drugs for the Pseudomonas or the MRSA, or where there was multi-drug resistance, the best drugs which were the highest antibiotics which were seen to work best were the piperacillin-tazobactam combination, the cefexime, the meropenem, and sometimes gentamicin and tobramycin. These were the drugs which were used. As we know, they work very well for the gram-negative. But they all required parenteral mode of treatment. This chart is essentially talking about the entire guideline. It is a very confusing chart. I have broken it down into a smaller thing so that you can understand it better. It's a very busy flow chart. So I've just broken it down into smaller pieces. What is the diabetic foot infection? It's defined when there is a wound, there is neuropathy, there is poor glycemic control, and there is vascular insufficiency. This is when we call it a DFI. What is the non-pharmacological therapy here? We need to cleanse the wound, we need to debride it, take culture, and then also assess what are the other infections, other issues which are there with the patient. Now, in the case of a mild DFI, as our topic today is, we are talking about the antibiotics. This is a breakdown, and I have made, this is really simplifying the whole thing as a take-home message. In the case of a mild diabetic foot infection, where the erythema is less than 2 centimeters, if we don't have any risk of MRSA, the drug of choice will be dicycloxacillin or cephalexin or cefuroxamine. In case there is allergy to beta-lactam drugs, you can use clindamycin. When there is a risk of MRSA, the drugs of choice will be sulfamethoxazole and trimethoprim, or you can use moxiclav. Sometimes doxycycline with amox and clav combination. In cases where there is beta-lactamase allergy, we would require to do an IND much earlier than any other patient. In the case of a moderate DFI, where the size is larger than 2 centimeters and the deeper tissues are also involved, when there is no risk for MRSA and we are giving oral therapy, sulfamethoxazole, trimethoprim, either with moxiclav or clindamycin is to be used. In case there is a risk factor for Pseudomonas or there are other allergy to sulfa groups, we can use ciprofloxacin instead of the sulfamethoxazole. When there is a MRSA risk, orally the drugs that we can use are again sulfamethoxazole, trimethoprim or doxy along with moxiclav. In times when there is an allergy, we will use clindamycin. When there is a Pseudomonas or severe allergy problems, we have to use ciprofloxacin in place of sulfamethoxazole or trimethoprim. Now, when IV therapy is given in moderate infection, the ampicillin alone will not work. Generally, we always say add more than one combination of drugs. So, ampicillin or ceftriaxone along with metronidazole, or we can use piperacillin tazobactam alone, or just add metronidazole. Sometimes vancomycin is added when there is a MRSA risk factor. In case of allergies, we will just do an IND consult, drainage of the abscess. Also, the route of therapy matters, and for how long we need to continue it matters, depending on the site of infection and the severity of the abscess. When only soft tissue is involved, it's a mild infection, we can give either topical or oral antibiotics. The setting is always outpatient. Give it for 1 or 2 weeks, at the most up to 4 weeks of treatment is required if it is very slow to resolve. In the case of moderate infections, we can give oral treatment, but generally it would be better to start with IV or parenteral treatment. It could be given outpatient or inpatient, and the duration of therapy is generally 1 to 3 weeks. In severe infection, always parenteral and then switch to oral when we start seeing resolution of infection. And as I said, we don't have to wait up to such point that the wound is fully healed. It's always started as an inpatient care because there are other systemic symptoms as well. The therapy goes on for 2 to 4 weeks. Whenever there is bone involvement, it's always longer, it's always parenteral, and the duration of IV antibiotics, oral antibiotics can sometimes extend up to even 3 months. But whenever there is bone involvement, we need to make sure that the end, when we stop, there is no further involvement of any bone tissue with having infection, because if we leave any amount of infection, it is going to come back. Now, I'm also going to cover very briefly the topical antimicrobials. There's not much to say about it, but any which ways, there are 3 categories: disinfectants, antiseptics, and antibiotics. What are disinfectants? They are non-specific agents with activity against virtually all disease-producing microorganisms, inclusive of those in the spore state. But since they might be toxic to the host tissue, that is the patient's tissue, we don't use them for topical treatment of wounds. The next group of drugs are antiseptics. They can be used either on intact skin and sometimes even on open wounds to kill or inhibit the microorganisms. The commonly used ones are chlorhexidine and povidone iodine. Now there are also various other products which release silver ions. They are approved and they are promoted for management of wound microorganisms. Now, antibiotics which are topical, they are chemicals which are produced either naturally or synthetically, that in the dilute solution they inhibit or kill microorganisms. They have a narrow spectrum of activity. They are relatively non-toxic to the patient, but they do lose effectivity as time passes. Most topical antibiotics are effective against the gram-positive bacteria. The common examples which we use in our everyday practice are bacitracin, mupirocin, any of these. Some which work on the gram-negative are the neomycin and the silver sulfasalazidine. Some systemic antibiotics are now also available for topical use. Example, clindamycin, metronidazole. Now we also get them in the topical formulations. Another set of topical, something that we can apply topically for better wound healing are the growth factors which are now available. The granulocyte colony stimulating factors. It's a growth factor available as a topical agent for treating the diabetic foot infections. Though the trials which have been done using the growth factors, they say that they do not affect the resolution or healing of the infection of the wound, but they definitely reduce the need for either oral or parenteral antibiotics. They also reduce the need for surgical intervention. They also reduce the total amount of hospital stay that is required. So they definitely have a role for the healing. Now I'm not very sure that this is a slide which should be here or no, but any which ways, this is something which I found. There was a study which was done by Cochrane and all, and they said that in a randomized control trial, the data on the effectiveness and safety of topical antimicrobial agents for diabetic foot infections is limited by the availability of small and poorly designed trials. They have done a study of some 20-30 trials which have been conducted, and they feel that none of them give us clear endpoints. So as per them, What is the need of the hour? It is to undertake a properly designed randomized control trial to evaluate the effects of topical antimicrobials for both the treatment and the prevention. Whenever this happens, I'm sure we will be able to produce some reduction in the oral and parenteral use of antibiotics. Thank you. I'd like to now call Dr. Amit Nagare for the next. Thank you.